Hemangioblastoma is a benign, i.e., WHO grade 1 vascular neoplasm, and it represents the second most common intraaxial tumor of the posterior fossa in adults after metastasis. There is a simple note regarding the most common cystic tumors in the posterior fossa. Pilocytic astrocytoma, which is mostly common, occurs in pediatric age group. Hemangioblastoma, which commonly occurs in adult age group. And cystic metastasis, which mostly common occurs in old age group. Approximately 25% of hemangioblastomas are associated with von Hippel-Lindau disease, which we will discuss in this lecture. The cell of origin, as the name of the tumor shows, is the hemangioblast. The hemangioblast is a type of stromal cells which is capable of two main functions: hematopoietic function and endothelial differentiation function. The hematopoietic function in the form of erythropoietin hormone secretion is responsible for the polycythemia found in some hemangioblastoma patients. The endothelial differentiation function is responsible for the formation of the mural nodule of the tumor. Von Hippel-Lindau disease occurs as a result of germline mutation in the short arm of chromosome 3 in this position. So we can use this mnemonic to remember the responsible gene. As von Hippel-Lindau abbreviation is 3 letters, the responsible is the chromosome 3, and there are 3 intracranial sites of vascular tumor formation in this disease. The hemangioblastoma, papilloma in choroid plexus, and hemangioblastoma in retina. Also, the disease criteria include endolymphatic sac tumor, renal cell carcinoma, pheochromocytoma, paraganglioma, glomus tumor, neuroendocrine neoplasm, and multiple pancreatic cysts. Let's do a histopathology and radiology correlation. MRI is the modality of choice in screening of hemangioblastomas because of the absence of the beam hardening artifacts and its multiplanar capability. Histologically, the tumor has two main components: stromal cells and abundant vasculature. We can call the stromal cell as a clear cell because it has a vacuolated or clear cytoplasm. Cells will be arranged around the new vasculatures, which are variable in sizes. We can see all of these features in this slide. Blood vessels with stromal cells having clear to foamy cytoplasm. This formation is responsible for the mural nodule, which enhances vividly due to its rich vascularity as seen in this image, labeled by the black arrowhead. These cells are either of secretory or non-secretory types. If the cells are not secretory, this results in solid type of hemangioblastoma, as you see in this picture. If the cells are secretory, this results in a cyst formation around the mural nodule filled with a yellow or xanthochromic fluid, resulting in the most common shape of this tumor as seen in this picture. The cyst appearance and fluid color depends upon the changes that occur inside the cells and vessels. If the cells secrete only, this will lead to a yellow colored fluid and homogeneous appearance of the cyst. If the vessels also bleed, this will lead to formation of a dark fluid and a heterogeneous appearance of the cyst. So the tumor has three shapes that we can see radiologically. The cyst with the mural nodule, this is the most common shape, the purely solid shape, the purely cystic shape of the tumor. Let's see some surgical pearls about hemangioblastoma. Cystic cerebellar hemangioblastomas may occupy a great variety of locations, but commonly are located posterior-inferiorly within the cerebellar hemisphere, especially along the distribution of the branches of the posterior inferior cerebellar artery or bica. Always remember that there may be more than one mass. After opening the dura, inspection through the arachnoid reveals asymmetry, increased vascularity and discoloration over the hemisphere containing the tumor. Choose an avascular area to insert a ventricular needle to aspirate the fluid, to evacuate the cyst and relieve pressure. The fluid characteristically is yellow, but may be any color, from yellow to black, since spontaneous hemorrhage does occur within these lesions. The neoplastic mural nodule must be totally removed. The base of the nodule contains all the feeding arteries and the draining veins. The situation is quite different when this tumor is solid and in the midline. In this case, the inferior vermis is divided in the midline. The tumor is then removed using magnification and a bipolar coagulation. Stereotactic radiosurgery can be utilized in lesions less than 3 cm. It cannot reduce the size of the cystic tumors. These tumors have the risk of rapidly enlarging cysts, i.e. within few months, and this can happen during pregnancy.